Okay. Well, I am Amy Killy. I am the clinical director at Weaver and Associates. I was trained in space maybe in 2020-ish, around there, and am certified in space, and help consult with those who are working towards their certification. And I'm very glad to be able to have both Amara Brook and Eli Lebowitz for us to all be able to have a conversation about space and its appropriateness or helpfulness or not. Um, with autistic clients, there's been some talk um, around whether it can be appropriate and helpful, and if so, how. Um, Amara Brook was introduced to me through some friends and colleagues, and Amara is a neuroaffirming psychologist in Nevada, affiliated with the University of Nevada Medical School and clinical psychology. They're author of the upcoming manual, Tailoring DBT, for autistic clients, and also has an excellent article out right now, a Frontier article, Tailoring Exposure Treatment for Autistics. And Eli Lebowitz is the developer of Space. He is professor at Yale Child Study Center. And I'm really glad to bring the two of you together for a conversation so we can really think more thoughtfully in a very neuroaffirming way around how space could be useful and effective, and where maybe it's not, and where it could, it's not all that useful or effective for autistic kids. So I wonder if we can just start, Ellie, if you want to just give a little bit, just, you know, where space started. And so what the initial intention of space was when you first developed it. And then Amara, maybe we could swing over to you to talk a little bit about some of the concerns that have come up.
Yeah. And
Yeah,
maybe just a tiny bit about like what exactly space is, because I imagine there may be some people listening who have no idea whatsoever what space is.
yeah, shockingly, there are still people not aware of what space is. Um, and I do want to say, though, I'm really glad we're having this conversation. I'm grateful to both of you, Amy, for kind of like making it happen, and Amara just for, kind of engaging in this conversation. It's something I've been wanting to do for a while, as I've realized both the importance of really thinking about these things very deeply, but also the importance of clarifying, for some misconceptions might that might exist around space and its application. And so I'm really glad that it's happening. And both of you are really very expert in space. I mean, Amy, you are a certified space therapist who is not just a certified provider, but also a supervisor of other people learning to do space. And Amara, you really went the full, the full nine. What is it? What's the unit you go nine of? I don't remember. But anyway,
Yards.
is it yards? I couldn't remember what unit you're supposed to go. Is it like
all in? That is pretty much
all in? That's
everything.
it.
So.
By doing a full 2-day training on space, and I think that's really important because having a conversation when you don't really understand what you're talking about is never a great recipe for success. But to the question of like what is space and where does it come from? Really, space is a parent-based treatment, primarily or originally for child anxiety and related disorders like obsessive compulsive disorder, increasingly adapted to some other adjacent problem areas. But the key thing I think to realize about space is that the words parent-based actually have a double meaning in a sense when talking about space, because one sense in which it's parent-based is the more obvious thing, and that is that it works through parents. Parents are the ones who go to the treatment sessions, not the child. Um, and that's one sense. But another sense in which space is parent-based is that it really focuses on parent change. It focuses on modifying parent behaviors in ways that will be conducive to better outcomes for the child. And that's the other, maybe slightly more nuanced or subtle sense in which space is parent-based. Originally, a lot of the impetus and a lot of the motivation for the development of this treatment came from just recognizing that there were a lot of families in which child-based therapy just wasn't really a great option or it wasn't really working. Right? There are a lot of children who don't want to go to treatment on themselves or participate in therapy. There are other children who struggle to, even if they do want to, for various reasons that can make it just a lot harder. And so a lot of the impetus for developing this parent-based approach was trying to answer the question, what can we do for families when a child is struggling with anxiety, with OCD, and they're not benefiting from our more typical traditional frontline child-based treatments. Over time, it's grown into just being another way of treating those children as opposed to a treatment only for families where child-based work isn't possible. So today, I think we just think about it as another treatment, but in some ways, it still carries some of that DNA, some of those initial roots that informed the way in which it's structured and the way in which it works. In terms of what happens in space, mostly space focuses on helping parents to be more supportive in response to their child's distress. The word support is very fundamental to the treatment. The name SPACE is an acronym for supportive parenting for anxious childhood emotions. And so the idea of being supportive is very fundamental and central to the work we do in space. And when we think of being supportive in space, what we mean is helping a parent to be consistently showing an acceptance and a validation and an acknowledgement of their child's very genuine distress, not to be dismissive of it, not to trivialize it, or to somehow expect the child to not struggle, etc., but to combine that acceptance with a confidence in a child's ability to tolerate a certain amount of distress, to cope with some level of distress, and to get through that. It's not, it's never it's never conceptualized as a demand that a child change their behavior. It's not about like, I know you can do this, so you're going to go ahead and do it. But it's a parent having some confidence that their child can survive being uncomfortable some of the time and to some extent, and showing that confidence to their child. And so that's one big part. If there are two legs that space stands on, one leg is being supportive, and the other is the gradual, systematic reduction in well-meaning but ultimately unhelpful accommodations of the child's symptoms. And so that's really what parents learn to do in space, to be more supportive, to gradually be less accommodating in a very positive, very loving kind of way. Um, yeah, I guess that's the small
Well,
nutshell I could pack it into.
yeah, and I know as we continue in our conversation, we'll circle back to these really important pieces around support and acceptance and what acceptance actually means, what confidence actually means, what accommodations actually means. But before we dive into that, Amara, I want to come over to you for a second, because I know you think very carefully about neurodivergent children and neuroaffirming treatments. And I'm not sure if I actually mentioned in the introduction that you also combine your clinical interests and skills with also lived experience. And so when you look at how space is typically taught and applied, where do you see the model landing well, and where do you see maybe cause for concern or areas that give you some pause or need for improvement, specifically when we're talking about autistic kids?
Yeah, thank you. So yeah, like you said, I bring lived experience both as an autistic person myself and as a parent and as a spouse in a lot of different directions. Um, And yeah, I think space is really promising in some ways. I mean, autistic folks have a lot of co-occurring anxiety, and we suffer a lot with anxiety. And so, treatments that can help us have some relief and live our, best, most fulfilled lives, I think are really promising. And at the same time, when we look at tailoring treatments, and this is not limited to space, but a lot of different treatments, we want to be really careful about what, and how we are targeting things. So there's been a lot of conflation in the past of, autism with other differences. The reality is autistic people do have a lot of anxiety, do have a lot of other co-occurring differences. And if there's things like anxiety that we would like to have less of, then of course we want to have the best possible treatments for helping with those things. And at the same time, from a neuroaffirming perspective, we don't want to be targeting the autistic differences themselves, right? We don't want therapies to be conversion therapy for autistic people to make them just seem more quote unquote normal, right? That's not affirming. We do want to help autistic people to live their, fulfilled, lives and, to help with things like anxiety, depression, self-harm, suicidality, OCD that are all unfortunately far too common in the autistic population. So I think that's one reason why I was interested in space. Also, I think from a neuroaffirming perspective, having more of an expectation for other people to adjust a bit rather than just always telling the autistic person that they have to do things differently is really a welcome thing. Because the history of interventions for autistic people have mostly been focused on trying to make them change to appear more typical for other people's comfort. And so delighted to have something that is focused on working with other people, not just the autistic person. At the same time, I do think there are some concerns, right? So one of them that I sort of alluded to is we want to be careful that we are only targeting the anxiety and not inadvertently targeting autistic differences that we actually need to be accommodating. Accommodation is sort of this tricky word that has multiple meanings in space and in the neuroaffirming world, but I kind of think of as sort of accommodation versus over accommodation. I know there could be other ways to talk about it, but we want to, for things like autistic differences, like sensory differences or communication differences or social differences, those are autistic differences that, to the extent possible, we want to accommodate and help with. And on the other hand, with something like anxiety, we know that when we accommodate anxiety in the sense of other people changing what they're doing in response to the child's anxiety, that tends to make the anxiety worse. And so we want to be very careful that we're clarifying what is just anxiety versus what is maybe looks like anxiety, but it's really coming from social, sensory, communication, learning differences, or things like that, right? Um, and so I think one thing is to really assess what are we targeting. This is really important. We want to make sure that we're accommodating and not targeting autistic differences while we are targeting the anxiety. Um, I think the other concern is that, now that I've done the training, I understand this doesn't have to be that way, but because space was developed specifically to work with the parents, there's an emphasis that the parents can do it, even if the child is hesitant about being involved. And at the same time, that can come across and can unfortunately lead to very authoritarian kind of top-down implementation that can, in my mind, reduce opportunities to even learn about what is social, what is sensory, what is communication, what is learning differences, um, or things like that. If it's just the parents deciding this looks like anxiety, right? And I think whatever lens we have, we tend to see everything as, like there's that saying, if you have a hammer, everything looks like a nail, right? So if we're thinking anxiety, then there's a lot of behaviors that could be based on anxiety alone, but they could also be based on these other differences, right? So we need to have very careful assessment of what's going on. So I think those were the main sort of areas of concern. I'm still optimistic that it can be neuroaffirming. I think we need to be careful to make sure that it is implemented in that way, though.
Well, maybe we could try to go through those concerns, and talk about them a little bit more. And then also, as Amara, you're saying, then let's get to what could the next steps be. But if we start with that assessment, differential diagnosis that you were talking about, Ellie, I wonder if you can start by just talking about when a clinician is considering using space. Um, what kind of emphasis, how much time do you suggest or think about in terms of that upfront assessment, specifically distinguishing anxiety really from any other diagnosis, to sort of set up space to be able to be as effective as possible?
Yeah, I would say, first of all, I think those are all valid, really valid and important concerns in the implementation of space. And I also want to acknowledge that in the same way that a treatment can do good, it is also possible for things to do harm, and that that risk becomes greater the more things really are viewed through a somewhat narrow, everything's a hammer kind of lens. And so I think these are really important things to be thinking about. To the specific question, the frankly, I think it is not even really specific to the question of autism to say that if you are going to apply a psychotherapy to try to treat a problem, you should have a good understanding of the problem that you are treating. It would be malpractice for a physician to prescribe a medication based only on hearing the first symptom without doing any kind of follow-up testing or evaluation or diagnostic understanding of the case, right? If you say to your physician, I have headaches, they're probably not doing a great job if all they do is prescribe aspirin without also checking whether your vision needs correction or you have a brain tumor, right? And I'm not, saying every person who has a headache has to be tested for brain tumor, but as a metaphor, I think we have to be responsible and ethical and good clinicians. And so if you are hearing symptoms, yes, of course, I think you need to spend time reaching some kind of case formulation or conceptualization. I think that good treatment relies on good assessment. And that is going to be true in autism, and it is also going to be true, if a child has thoughts about suicide, it really matters to me whether that is an obsessive thought that is plaguing and tormenting a child because of an obsessive compulsive disorder, or whether that is a depressive thought that is filling their mind because of unhappiness and a desire not to, to not be alive, or whether there is some other reason that, maybe there's some distress that's actually happening in the child's life that is causing them to struggle so much with their daily life that they're imagining an escape from it. And those are all plausible hypotheses for why a child might be reporting depressive thoughts. And it would be malpractice to jump straight into treatment without spending that time doing assessment. And so I absolutely, it's hard to give a X many minutes. The number of minutes is the number needed for you to feel like you have a good sense of what is the problem that you're treating. But then it's also an ongoing process, right? Because maybe you do understand that the child has autism and also has anxiety. Okay, you're still going to be doing ongoing evaluation and understanding and refining your understanding week by week as you're also providing the treatment.
Mhm. And it feels like there's a real parallel between that. Like, obviously, as the clinician, we really need to understand the diagnosis and do a full assessment to understand what we are sort of jumping into. But then also, there feels like there's a real parallel process with the parents, helping parents really understand their own kid and who their kid is, and you know, what might be anxiety, what might be autism, what might be ADHD, what might be OCD, what, like really thinking through those different pieces. Amara, I wonder I think you actually referred a little bit to this already, but some of the risks when that differential diagnosis doesn't occur or isn't as thoughtful or as in-depth as Ellie's talking about, when that doesn't happen so carefully, and what that might look like, especially for an autistic child who is also experiencing anxiety when that gets missed.
Yeah. So I think I do want to say something about that, but I also want to say something about, I think, why the assessment ends up being fairly cursory. I mean, there's a lot of pressures on our system to sort of get the assessment part done quickly. There's not necessarily a lot of time allocated for it. Also, understanding of autism is really evolving very quickly. And so there will be a lot of autistic kids presenting to anxiety treatment who have not even been identified as being autistic. And that is actually more likely if they are highly verbal, if they're assigned female, if they're ethnic minorities, if they're highly intellectually capable. All of those groups are less likely to have been identified as autistic. But they're not at lower emotional risk. Like those groups are actually a fairly high risk. In fact, there was a recent study that autistic adults of higher IQ were at higher suicide risk than other autistic adults. We're talking about children here. I just want to make the point that emotional risk is not the same as whether somebody's being identified or not. So there are probably going to be a lot of these kids coming to anxiety specialists who have that anxiety treatment hammer. And that's kind of the main thing they're looking for. And maybe the parents don't even know that the child is autistic or identify any of these things. So it's one thing if you have a child who is known to be autistic who comes into the clinic and you can be like, aha, okay, we should be looking out for these differences, social communication, stimming behaviors, sensory differences, intense interest, need for routine, all the, detail orientation, all those things that we know are related to autism. But what about when a kid arrives who has not been identified as autistic? I would say for most kids, we need to be keeping an eye open for those things. And I come back to this, and this is where my sort of DBT bias comes in. We always want to know what the function is of a behavior before we do anything to specifically target it. And so I think we want to be really careful in even I like the suggestion that it can be an iterative part of the process because one of the things that jumped out at me in the training, because we had a lot of case studies, was that in some of these cases, the behaviors that were being identified as targets for anxiety intervention potentially could be due to other things, like a kid who was hesitant to ride the bus, or a child who didn't want to eat a certain thing, or things like that, or not wanting to go to school. Like there could be a lot of reasons for those things that may or may not be just anxiety. It might not be basically anxiety, but it could be that it looks like anxiety because they're like, no, no, the bus, that's terrible. But there's like a whole underlying level of reasons, social, sensory, whatever, that they don't want to ride the bus. And so we need to be, I think, careful with that, even if the child doesn't have come in with a formal autism diagnosis. I think the risk is if they, to answer your actual question, Amy, is if we're not careful about that assessment, if we're over identifying things as being based on anxiety and really not questioning that, is we could end up inadvertently invalidating the child's actual needs and actual differences. And we know from biosocial theory of problems with emotion regulation developed by Marshall Linehan that being chronically invalidated is really harmful, really traumatic, and tends to lead to worse emotion regulation problems. You can end up with people kind of sucking it up and, trying to please the parents and trying to do whatever and masking and, really kind of falling apart over time, burning out, having longer term mental health problems. And so I think we want to be really careful that we're not doing that. And I think it is possible with careful assessment to collaborative assessment, I would say, to really make sure that we are targeting things that are anxiety and not anxiety that's actually reflecting an underlying problem that should actually be accommodated, problem solved, etc.
Yeah, I think we'll come back to because I think you, Amar, have brought in the language around collaboration and collaborate quite a bit, and probably we could talk about that a little bit more, and I'd like to in a second. But before we get there, I wonder, you've talked about social differences, sensory differences, communication. Um, Certain things that for our autistics we want to accommodate versus I think earlier on you said you sort of differentiate in your mind between accommodation and over accommodating. And I wonder if you can talk a little bit about sort of the concern that space is how in the way that many people understand space to be risks accidentally targeting autistic needs rather than accommodating them. And so I'm wondering if you can help us understand what that might look like in practice, or give an example of where that error could could land and the risk there.
Sure. So to return to an example that I just mentioned, right? Like let's say that a child refuses to ride the bus, right? There could be, or go to school, or go to parties, or something else, right? There could be a number of different reasons for that, right? One reason could be that they're just anxious about those things, but there's no actual problems that they experience any different from any other child in those settings, right? So that might be more of a social anxiety type reason. And that might be something that is that you would accommodate with space, like the parents gradually reducing their support for avoidance of those things, like reducing their kind of over accommodation of that social anxiety that's probably making it worse. But what if the child is experiencing sensory pain in those settings? And that's something that needs to be accommodated. But the parents don't know that because all they see is that the child's avoiding, refusing to ride the bus, right? And getting very emotionally distressed when somebody suggests riding the bus, right? What if other kid is bullying them on the bus and the parents and the bus driver also don't know about that, but all they see is avoidance of riding the bus, right? So we could potentially, if we were just looking at that and saying, oh, avoidance of riding the bus, that's social anxiety. Let's just make the kid, like reduce the parental accommodation. We're not taking them to school anymore. They're going to have to ride the bus or they're going to have to ride the bus to get home. Um, but with no problem solving around the social, the sensory, right? So now we're forcibly keeping the child in a problematic situation with no help and telling them, oh, I'm confident, you can deal with it, right? Well, really, that expression of confidence is supposed to be about, I'm confident you can tolerate some distress. But instead, what we're telling him is, I'm confident that you can just suck it up and not have your needs met and tolerate this pain and these unsolved problems in the situation without actually solving those problems, right? So if we're going to be a neuroaffirming, we want to make sure that we're looking at are there autistic needs that are that are not being met and make sure that we're providing support for those things at the same time that we're not you supporting excessive avoidance related to anxiety.
Mhm. Yeah, you said before about, what's the function of the behavior, and that feels like a key to trying to determine what's accommodating and appropriate for an autistic child and maybe what is an over accommodation. Ellie, I wonder if you could talk a little bit about how you think space clinicians should be thinking about accommodating autism or even ADHD, other sensory issues or processing differences, while still working on the anxiety. You
Mhm.
know, how do we distinguish that, and what does that actually look like?
Yeah. I think Amara said it so perfectly in saying we want to make sure that when we're expressing support for a child and we're saying we know you can handle this, that we are saying we know you can handle some distress and you can be uncomfortable sometimes and get through that. We're not saying you don't have, a problem, or you just have to conform to everybody else's expectations regardless of who you are, or you have to put up with the fact that you're being bullied on a bus because that is right, like, which goes even beyond whether you autism or not,
Mhm.
right? How absurd would it be to say, well, you're being bullied, so what, right? Like, we're confident that you can handle that, and therefore we're not going to intervene. I think it's so important because really, even when it comes to just anxiety, right? Like, say it really is just anxiety, the goal in space is not to say like you're never allowed to be anxious, right? Like, that's not really a plausible or a reasonable message. In fact, if you think about it, actually we're kind of saying the opposite. We're saying like, yeah, it is okay to sometimes be anxious and to be able to get through that, but that doesn't mean that there can be no accommodation ever of any of your of your symptoms or personality or preferences. And so to the question of like, for the clinician, I'll say it very bluntly. I think that trying to apply space for an autistic child without yourself as a therapist having some good understanding of autism is
Mhm.
probably not a recipe for success. I think it's probably rather foolhardy to do that. Now, you have to get experience because we need experienced, clinicians. And so I will say the same thing I say every time I'm asked this. Get really good supervision from somebody. If this is your first time, maybe you've had a lot of experience with anxiety and you haven't really dealt with autism, or at least you haven't really thought about it explicitly. Get really good counseling or consultation or supervision from somebody who really, really gets this, because I think otherwise you are inviting challenges. You said before, Amara, about the like families where somebody maybe isn't diagnosed. And I've experienced even a more extreme version of that, which is maybe somebody was assessed 3 years ago, 5 years ago, when they were this age, when they're that age, and the family now knows that the child doesn't have autism because the assessment showed no, they don't have autism. Now, that can then carry on forever, right? Like, but as you said, our understanding of what it means to have autism has also evolved. Like, just go over the past, I'm not talking about the 50 past years where it's like, just not even that closely related, but even just over the past few years. And your 3-year-old, well, you checked because you're a responsible parent and you were told your child doesn't have autism. Now they're 7 or 8 or 9. And so you go to the doctor and you, as a clinician, you're being told this is ruled out.
Mhm.
Does it actually mean that it's, ruled out? That's why you still need, I think, good expertise. You need good knowledge, or you are, inviting problems. And in my mind, it really isn't always about, is this an anxiety or is it an autism like symptom, so to speak? It's more, is this a situation where the best thing for this child is getting a little bit better at tolerance, or is this a situation where that's actually not the best recipe for, for this particular moment, or for this, for this thing? Even when it's just anxiety, we don't come at it with just like zero accommodation ever, right? That's not really the best representation um, of space. And so I think, yeah, that if you're a clinician, you have a responsibility to your client to be able to have a good grasp. And like we all get better, right? Like we're always learning, we're always getting better, but you have responsibility to put in the effort to understand what you are treating.
Sure, if you want to provide an evidence-based treatment, you have to understand what the current evidence is. And so you have
Yeah.
to,
And
you have
that's
to,
definitely not just with anxiety, right? But like Ellie made such an important point. Like you really need to have a deep understanding of autism and how that shows up as well. I
right.
think the other thing is I would say about one thing that was helpful to me in terms of the training was seeing the perspectives of other participants. There were some, well, some had nothing to do with autism at all, but some were also like sort of neuroaffirming practitioners who work a lot with autistic folks. And some were more coming from a more traditional approach to autism, quote unquote, therapy, that was more like focused on changing the autistic characteristics. And that was very interesting because I was able to see like in real time and talk to people. And those coming from sort of the neuroaffirming frame had generally similar concerns that I had. And some coming from a more like traditional kind of target the autism frame, kind of make those kids more normal, were seemed perfectly happy to consider applying space in a way that would further that goal. And so I think we need to be really careful, like even when somebody's getting hopefully additional supervision or consultation, on what to look for in potentially autistic kids and how to, accommodate that. We need to be very careful about that as well because there are like autism experts out there who are working with a pretty old school, not neuroaffirming view in current terms of like targeting autistic characteristics for change. And so I would just say like get consultation, supervision, training, and make sure that you're getting it, from an up-to-date perspective on what's involved with autism and, how to work with it in an affirming way.
Yeah, I think that that's really important. And I'm wondering, um, sometimes I feel like clinicians come to this and they just don't know what they don't know. And my hope is that this conversation will at least bring out some light bulbs for some people of like, oh, wait, hold on, I should really think about this some more. I should get more, more information around this. But do you, this might be too hard to answer, and so we could skip over it if not, but do you think that there's ways that space-trained clinicians can recognize for themselves when they've crossed the line from, supporting meaningful growth in some way to into maybe pressuring um, or some sort of conformity in a neurotypical, no, with neurotypical norms, you know, where they've just crossed the line. And so I think you have both have talked about it a little bit, but I think it's worth sort of putting, you know, dotting this I a little bit, or putting a point on it, because I think it's important here.
I think it's hard because I think proactive is going to be much more effective, right? Because once you really commit to targeting something in space, and maybe Ellie can, step in here, but there often, there is some distress, and so it could be very easily dismissed, even if the child is having really underlying ongoing problems. If their perspective hasn't been invited in the process, and what they've received as you can handle it, kids, suck it up and deal with it. I'm not saying you'd use those words, that wouldn't be supportive, but if that's the message they're receiving, they may just be sort of giving up, kind of learned helplessness, like, masking their distress and learning that nobody cares about their needs. And I think that would be terrible, right? But how would you tell unless in the process, they're saying, but my ears hurt, or something that's very obvious that then, it makes it clear that there is a different kind of issue going on. But I think it's going to be much more effective to um, proactively assess what's going on with this problem before we target the problem, because there's damage done by the time that we're sort of kind of invalidating by accidentally targeting the wrong thing. I would say in terms of learning about sort of a neuroaffirming perspective on autism. There are some great resources out there. I just wanted to throw a few things out. This is, sorry, grab a book. These Is This Autism books are a great overview. This is one for everybody. It's our mutual colleague,
Excellent. I can
Killy.
second your recommendation. I think it's excellent.
Um, Excellent. There's also this one, which is for people assessing autism, which is not to say most clinicians will be doing that, but it gets into a lot more detail about ways that you can assess various autistic characteristics. There's some great podcasts, like Divergent Conversations and the Autistic Voice Project. I would say some things on like tilt parenting. I would say that there's a lot of resources out there to learn, you know, to learn to do better. But I think being proactive is probably going to be more reliable as a way to prevent harm than just trying to hope that some obvious signal comes out at a later process.
Well, and it again speaks to how that beginning part of space is so important and maybe sometimes overlooked. That really, really doing a significant assessment. Also, really, how are you helping parents really understand their child, decreasing the stress in the household, having parents be able to recognize their own anxieties and how are they, managing their own feelings feels like an important piece of the beginning part of space that maybe we don't give enough of attention to. I don't know, Ellie, if you have other thoughts.
Well, first of all, of course, the more you can front load, the better, right? The better your assessment, the better. The more careful you are about choosing even after your assessment, the more careful you are about choosing what you want to target, the better. And we do have some pretty well spelled out criteria for what are you going to choose to focus on. And so the more you do that, the better. I also think it's important to remember that the way in which you do space is not by suddenly stopping to accommodate your child's symptom. There's a pretty thoughtful, I would say, approach where we're really thinking carefully about what is the precise change that we're going to make. How are we going to communicate this to a child? It's so important, right? Like the experience of a child whose parents just change their behavior is dramatically different from the experience of a child whose parents spend a few weeks communicating in a really positive way their support for that child and then present their plan with a rationale, with a positive rationale. And then, yes, you are also going to be doing some ongoing monitoring once you have started. We do want some distress tolerance. It's true. If you say, look, if this proves to be challenging, we pull the plug, then you're reinforcing in your child the sense, I really can't handle anything, right? Like, as soon as it was hard, my parents saw that I can't handle it, so they backed away. And so, of course, you do need a certain amount of distress tolerance, but you also want to be monitoring that. You want to be thinking about it. What does that look like? How are you responding to it? And then I want to add another thing, which is you were saying, like, how are you going to notice when things are going wrong? A big way that things can go wrong is when we slip from what am I doing differently to what do I expect you to do differently? And I think that is probably one of the more common distortions of space. For example, it's easy to word things in the language of accommodation, but they're actually not, right? Like, for example, if I were to say, I will no longer accommodate by allowing you to pace your room for 3 hours a day. Well, what does that actually mean? Does it mean that I'm no longer accommodating, or does it mean I now place a demand on you to not engage in that behavior? I would say that's a bad target for
Mhm.
space. It's not a good target for space. Whether or not you think the behavior is problematic, it's actually not a good target for space. Because although you're using the word accommodate, what you're actually saying is, I need you to stop this. right? I need you to not do this behavior. And so I think being really careful about maintaining space's focus on only requiring change in the parent behavior is it's a good way to stay out of a lot of trouble that you may otherwise, find yourself in. And the second question I think that's good to ask is this actually impairing? Right? Is this actually even like, is it a problem for the child or is it a problem for me?
Mhm.
That's not the same thing. A lot of child behaviors, characteristics, symptoms, and tendencies can be irksome, can be problematic, can be, distressing. And I say that not dismissively because being the parent, if your child is encopretic and cannot not go to the bathroom in their clothing, that is honestly distressing for most parents. And I wouldn't judge a parent who finds it distressing because of course it is. It's unpleasant to clean it up. It smells bad when it's, there. You are allowed to feel like that's distressing to you. However, that's different from saying it's a misbehavior or it's something that you can legitimately simply demand stop. If your child has Tourette's, they may make sounds that are legitimately distressing to you, or other tics, right, that are legitimately distressing to you. Are you a bad person because it bothers you? I don't think so. I think you're just a human person because it bothers you. But does that mean that it's now okay to say to this child, you're doing something wrong? No, I don't think so. And so if you keep the focus on your own behavior and you remember to ask yourself, like, is this a problem for my child or is it only a problem for me? You may stay out of some of the trouble that you might otherwise find yourself wading into and then having to correct course because you realize, okay, maybe I've gone in the wrong direction.
I feel like this bridges us right over into talking about the child's voice in the process, or what it's called unilateral steps in space. And I think there's been some confusion around what that means. I think there's some concerns around what that means. And Ellie, I wonder if you can sort of define a little bit better sort of what you mean by unilateral steps when you use that in space, but also what do you think about the child's own voice in the process? Where does that come in or does it not? And is there a place for collaboration with children in this model?
Yeah, we use the term unilateral steps to indicate that it is possible for a parent to do this process in a unilateral way, meaning in a way that actually doesn't rely on a child's active collaboration with the treatment process. Now, I want to say that's actually a tremendous strength of this treatment model because for a lot of children, if you were to say, I will only help you when you decide to be an active partner in this process, for a lot of children, that means not helping them or not helping them for a long time and with accumulating harm that is happening from them not receiving treatment. And so it's a really important strength of this treatment model and actually quite a unique one in the context at least of internalizing symptoms like anxiety. It's quite unique that it's possible to do this treatment even when a child is not cooperative or open to change, etc. However, that does not mean that it's the only way to do the treatment or even the preferred way to do space. If I have a choice between doing this treatment process in a collaborative way, then that would be my choice. I think that is better. In fact, sometimes you will start in a less cooperative way and then be able to have more cooperation. I do distinguish between talk and cooperation, because it is possible to talk in a way that is not cooperative. That's just that's a human capability. We can have long conversations that are not cooperative. But and so it's not like like the important thing is not is there conversation that is happening, but is there actually cooperation? When there is, I think it is preferable, nicer, more fun for everybody, honestly, and probably more effective than doing it in a very unilateral way. However, when that's not a possibility, then I think it's important for parents to be able to say, what can I, as a responsible parent to a child who I understand to have a challenge, to have a problem that is a risk for them, what are the steps that I can responsibly, ethically, and supportively and lovingly take in order to help them to be as well as I can? And so that's the way that I'm thinking about what we call unilateral steps in space.
Mara, I wonder if you want to jump into thinking, excuse me, for about autistic children specifically, and maybe even including those with a PDA profile, how this unilateral approach might land and could be done differently, or the importance of that collaboration that Ellie is talking about.
Yeah, definitely. I mean, I think it is one thing to say that if it is impossible to collaborate with a child, like last resort, it is possible to just have the parents do this and not to have it be collaborative with the child. But I think also when a treatment can get simple, I mean, I think a lot of people perceive, and I have heard this from other neuroaffirming conditions, that space hands down is unilateral, authoritarian. The child is not involved in setting the goals, or and I know that doesn't have to be that way, but I think many people perceive it that way, and it concerns like my first exposure um, to it, aside from reading some articles, was listening to the parent book. And it struck me as, yeah, parents could be really non-collaborative about this. And, there wasn't, I realize you can only emphasize so much, right? But just kind of like the assessment's really important, but that differential assessment was sort of like a side note. Also, the collaborative aspect I felt was kind of a side note. And so I think there's a real concern when we were working, my colleague Rachel Kraus and I, who just wrote the Tailoring DBT for Autistic Clients, um, came up with this idea of like neurohumility. And the idea is kind of, it's sort of a form of cultural humility for neurodivergence, like realizing there's a lot that I don't know about your experience. And I can't just magically know it if I don't share your neurotype, or even if I do, but I don't have your experiences, right? And the only way I can really learn about that is to really, really openly, warmly, validatingly invite communication about what you're experiencing, about your needs, right? And I am concerned that if people feel like, well, mostly it's unilateral, but also you could collaborate, that they'll just skip right over that. And so I think if we want something to be, neuroaffirming, we came up with this like ascent model for what's neuroaffirming. Well, one thing is we need to be affirming and autonomy, supporting and setting goals. It's really hard to do that if we're not having any sort of collaboration. We need to operate with neurohumility. Hard to do that without any sort of collaboration. We need to be trauma informed. Well, parents might know about the child's trauma, but I would guess most autistic people have lots of traumas that their parents do not know about. I mean, we all know that kids don't share everything with their parents, especially if maybe they haven't received the most validating response. And then we want to accommodate autistic needs. And it's really hard to know why, if that kid isn't riding the bus because of social, sensory, or just anxiety, quote unquote, if we're not communicating with the child. Granted, I'm sure there are some cases where, we're getting a lot of information is not possible. But I would really invite more. For example, Ross Green has collaborative and proactive solutions, right? This was also designed for kids who are very challenging to collaborate with, maybe who are having very extreme behaviors, so not always extreme, but behaviors that parents find challenging and don't understand super well. And there's a whole process for sort of you're not wanting to ride the bus. What's up? And then if the kid says, I don't know, or then there's a whole process for like inviting collaboration with the child and taking that very, very seriously. And I think something like that, not necessarily that textbook approach, but something like that combined with space could be very, very helpful because then we're getting a lot of information about the child's experience that helps with understanding, not targeting the wrong things. It also tells the child that your concerns are valid to me. I want to hear about your concerns. Does that mean at the end of the day that the parents are going to continue doing all the OCD compulsions, even if the child doesn't want them to? Like the parent might still have to say, they might still have to collaborate on something that isn't the child's favorite outcome, but the parent's going to have a lot more information. They're going to communicate that in a very collaborative, non-authoritarian type of way. So I think I would just in general prefer to see a lot more collaboration, especially when there's a high degree of, likelihood of not understanding some of that child's experience and the differences related to their neurotype. The issue with PDAers is another one. So I intentionally said all that without getting into that. But so PDA is technically pathological demand avoidance. I prefer the term pervasive drive for autonomy. But these are folks who are usually, maybe not always, but usually autistic. And it's mostly thought of as a subtype of autism. And these are folks who need a highly collaborative approach, who tend to guard their autonomy, their self-direction, their being in control above almost everything else, and react very badly to top-down and compliance and reward and punishment-based approaches. And I realize this isn't a reward and punishment-based approach, but I'm just saying like this is, generally when we're working with PDAers. And across the board, talking to other folks in the training who also work with PDAers, there was a big concern that if something is just communicated, so this is what we're doing, that you could get a very much more negative approach from PDAers than if it's done in a collaborative way. And so I think I would say for the reasons I was talking about with neurohumility and assessment and all the things and making sure we're not targeting the wrong thing, I think we want to be collaborative as much as possible with any autistic person that we're doing space with. And if the child has PDA tendencies, then we want to be extra collaborative because the consequences are likely to be even worse for not being collaborative. So I know that was a long response, but
No, I think it's really helpful. And I think, we've talked today a lot about the significant importance of that differential diagnosis and assessment and the ongoing assessment, which requires collaboration. It requires collaboration with the parents. It requires collaboration with the child. It requires collaboration with maybe other people who are in the child's life at some point. But that differential diagnosis and assessment, the inviting collaboration, and really being able to recognize what's an accommodation that should be in place versus one that is not helpful or useful in some way. Meaning, if we're again, that differential diagnosis between what is rigidity because it's autism, for example, versus anxiety. Are there other?
this is sorry. I just want to jump in also and mention like ADHDers. I think there's
Yeah.
the topic we've been talking about, but there's a huge overlap between autism and ADHD, especially most estimates, the majority of autistic people have at least an intent of ADHD. And that's yet more opportunity for things to be mistargeted. For example, things that commonly come up when I work with parents, child wanting the parent to check over their homework. Uh, something that may be an appropriate accommodation for an ADHD child. Now, 12 times, maybe not, but a few times, or maybe the parent has ADHD also, and the child has had the experience that the parent misses mistakes in the homework. Not to say we can never have any mistakes, but there can be checking that is appropriate as kind of an accommodation, or the child wanting the parent to sit next to them while they are doing their homework, to help, reduce distractions, cue them, help them stay on track. Child needing to process things out loud with the parent, right? Lots of ADHDers are very external, not all, but many kind of external processors, and they need to talk through something before they can figure out their thoughts about it. Those could all be things that could be seen as anxiety and inadvertently targeted, whereas they may actually be really important accommodations for an ADHDer. And I'm sure there's similar things for other, forms of neurodivergence as well. But I just wanted to kind of highlight that also.
Yeah, I think that's really important. So I'm wondering, are there any other adaptations that either of you think about when you think about space, specifically for autistic children, aside from what we've talked about in terms of the differential diagnosis and increased assessment, which again, as we've been talking, actually all these things are good for any child, right? For any child, there should be a really thorough assessment done. It should be ongoing for any child. Having collaboration can be really worthwhile for any child, recognizing what behavior should be accommodated or not accommodated. Um, is there anything else that either of you think about in terms of adaptations to the standard space protocol that you'd want to see shifted or changed in some way?
This is not really a different adaptation. I'm still reflecting on what you were saying, Amara, about it. What would be a good way to structure the invitation to cooperation in a sense? And I think there's like an irony to me in that in developing space, and this goes back like a good number of years now, but in developing space, I think it felt like the cooperation piece we have, right? Like that's the part we have. And what we need is a way to function even when that cooperation isn't there. And now we fast forward to today and we're saying like, okay, it feels like we know how to do space without cooperation, but maybe we need to do an even better job of making sure that we're not skipping the invitation to cooperation. So there's like a little bit of an ironic kind of circle being closed there. But I do like the suggestion of maybe helping to structure for clinicians. And I agree that the manual for space doesn't really do that. But maybe helping a little bit more to structure what does it look like to test whether cooperation is. And again, that also is not something that I think should be once. I think it should be an ongoing thing. And I mean, we've said this now a lot, but I could not agree more about the importance of the assessment and of choosing your targets wisely. The thing that makes that so important is that it takes a while to know after you start working on something, whether it was a good idea or a bad idea, right? Like when you were talking about the issue of PDA, you're saying how, maybe other people in the training were talking about how there would be a big response. And the reality is that a big response is actually not a great indicator of is this a good idea or is it not a good idea? You need a little bit more. You need to either be wiser in choosing or a little bit more time, I think, in order to see. Because a big response is sometimes a short response and sometimes a long response. Sometimes it is a necessary step toward change, right? Like sometimes change does come in a stressful way. And so it's really hard to look at what is the immediate response of a child and say, oh, this was clearly a good idea or a bad idea, which just makes that front loading of assessment and choosing targets, your sort of discussion, Amara, of like the homework question is a great example to me. I can't say whether accommodating your child by sitting next to them when they do their homework or checking their homework 3 times is a good idea for you or a bad idea for you, right? I can't say that without knowing a lot more about what is the function of that behavior. Even within anxiety, there can be multiple functions that can drive that behavior, right? Like maybe you have generalized anxiety and are worried about mistakes, but also maybe you have separation anxiety and just get freaked out if I'm not right there. And so you want me to sit there, and then you can have things relating to ADHD, you can have things relating to autism, et cetera, et cetera. And so it's actually impossible for any clinician to just hear the symptom and know, is this a good idea or a bad idea? I do want to acknowledge, like we're talking about the importance of assessment, and it is very true. In fairness to all the therapists out there, I do want to acknowledge that differential diagnosis is the hardest thing in our field, basically, right? Like it is very difficult. And so I don't want to, imply that it's easy or simple, but that just means I think embracing the fact that it's difficult and being willing to go through it, right? Like accepting that we don't always get it perfect, and we don't. We make mistakes, but being willing to embrace that at least there is a process to work through, I think is really important. And by the way, I love this term, neurohumility. That's a good, congratulations. That's a good term to coin.
Shout out to Rachel for that. That was
Okay.
we came up with. But yeah,
It's a great
amazing.
term.
So aligned with like the huge literature now on the importance of cultural humility and all kinds of outcomes in therapy. So very, very similar. Yeah.
Yeah, it's great. And it applies to like everybody, right? Like you never really know another person's internal experience. But
Right.
yeah, it's good.
Um, Yeah, well, I really appreciate Amy, your helping, organize this and, Ellie, your openness to these conversations and like eagerness to figure out how space can really be more neuroaffirming. I guess I feel like I've mentioned most of the things that I would want to, but I think one of them is in terms of the collaboration, the communication, we need to be patient in trying to collaborate with autistic children. I mean, some folks appear to be more verbal than others, but a lot of folks have autistic folks may need more processing time or for responding to something, and so you may get rote responses like I don't know or not anything or something like that. Like we may need to just be more patient and more persistent in offering collaboration, and so that's one thought, and another is really in terms of collaborating with the child, making sure to incorporate their intense interests, which thankfully or mostly we don't perceive as a bad thing these days, even if they were maybe targeted in the past. But I think, in terms of a child's motivation to do some things that are uncomfortable, that may be one of their strongest motivators. And I don't mean like in a manipulative way, like please don't withhold the interest until they do what you want. I know space is not about that anyways, but what does the child want to do? Like what do they want to do that maybe they can't do right now because of anxiety? Like what would be something they would like to be able to go to, or some activity they would like to be able to do, or some long-term goal that they have. Like so we can really make sure that we're aligning the treatment with the child's passions and interests and goals, like not in a manipulative way, but in a way that is really autonomy affirming. So I would really suggest, including that. And lastly, considering that because autism is very genetically linked, a lot of parents of autistic kids are also autistic. And whether they know it or not, many don't because, assessment was not what it is. Well, now it's far from perfect now, but it was even much less perfect in, many decades ago. And so there's a lot of undiagnosed autistic parents of autistic kids. And I think it's just an important consideration to keep in mind. And but I think it's healthy for everybody in the family to think about what is everybody's capacity. We don't want to be pressuring, the kids to do something differently just, for other people's comfort. And at the same time, we need to consider sustainability of the accommodations that the parents can or can't provide and kind of avoid that thing where there's, sort of over accommodation and then no accommodation because the parents run out of capacity to do the thing or, things like that. And really be considering the parent's neurotype as well and the treatment, especially a treatment that's mostly focused on the parents.
I feel like this has been hugely helpful, and my hope is that this is just the start of conversations to happen, and conversations that happen here, but also beyond. I don't know if either of you have any last words that you want to add or what you hope for next with this, or what you hope people have gotten out of this conversation.
I mean, I think this conversation has been a wonderful first step in terms of clarifying what autistic affirming space looks like. And I would love to continue to see coming out with more guidance around that, different formats, like basically, kind of, checklists, guides, things like that, that people can use to make sure that they're doing this in an autistic affirming way. And I would include what this looks like for all the different iterations of space, space for young adults, space for ARFID, which has a lot of sensory things related to it often and is very much more common in autistic folks. So I think there's a lot of need to clarify what exactly that looks like in, clear and concrete ways so that therapists are figuring out how they can do this in an affirming way.
Yeah, I agree. I think first of all, I've loved the conversation and agree with both of you that I think this is the first, of a series of conversations and different ways of working on it. I think there can be, more conversations like this. I think there can be some like product in like you're describing. I think it is important to acknowledge that preliminary indications are that it can be helpful, right? Like I think we need a lot more clinical trial research, but preliminary indications are that space can be helpful for anxiety in children with autism. And so I do want to, at least note that. To me, maybe the core foundational, sort of shared understanding that we can build on is the understanding that it is that it's possible to tolerate a certain amount of distress, and it's important for a child's well-being not to grow up with the understanding that they can't, with the understanding that any discomfort or distress is harmful. That's where if we were to flip the conversation from the risks of space for from a neuroaffirming perspective, I think sometimes the risk of a neuroaffirming perspective is when it becomes distorted in the same way that space can be distorted into meaning something that it doesn't. I think that can be distorted into the idea that being affirming means believing that a child cannot handle discomfort or distress at all, and that carries really significant risks. And so I like that we're sort of there's this meeting of minds to see, okay, how do you bring that understanding, but do it in a way that is affirming, that is accepting, that is positive and safe and healthy for a child. So yeah, I think there's a lot more conversations to come, and I'm really grateful to be part of the conversation.
I think we want to be really careful that we're not equating all the different kinds of distress. Like obviously, as a DBT therapist, I'm in favor of, that people can learn distress tolerance and can tolerate distress. I mean, I also run ultra marathons for fun, so obviously I'm not allergic to distress. But at the same time, I think we don't want to equate all the different kinds of distress. Like there's some data that autistic people do not habituate to sensory stimuli in the same way that other people do, or nearly as readily. And so we want to be kind of careful that I'm concerned that well, you can tolerate distress could be, seen by maybe without a lot of nuanced perspective as, okay, so fine, you'll be able to get used to that way too loud noise eventually, or, you can just suck it up and deal with this sensory thing. And I mean, clearly it is distress, but not all distress is created equal. I think the other thing that could be helpful is direct teaching of distress tolerance skills if kids and or their parents don't have them. And it's good evidence from DBT that teaching distress tolerance skills can be quite helpful. That combined with a space type approach, I think could be quite helpful.
All right. This is great.
Thank you.
Thank you.